Associate Professor in the Department of Paediatric Surgery, extend a very warm welcome to Chairperson Emeritus, respected Dr. M.L. Sunkar sir, respected dignitaries, respected seniors, my dear colleagues and residents. Before we proceed to the case presentation, I shall briefly present the work being done in the Department of Paediatric Surgery. The departmental function began in 2014 September. Within a short span, we had the opportunity to do our first neonatal surgery, and that was a case of esophageal atresia with tracheoesophageal fistula. Since then, we have done more than 45 esophageal atresia with tracheoesophageal fistula, and the smallest baby discharged with this diagnosis successfully operated in our institution is 1.1 kilogram. We have successfully treated complex recalcitrant esophageal strictures and recurrent tracheoesophageal fistulas. We also got our work published in the field of neonatal surgery. So far we have done more than 350 neonatal surgeries. The common among these are listed here: the congenital diaphragmatic hernias, all neonatal intestinal obstructions and rectal malformations, and neonatal neurosurgery is being done at our institute. In pediatric surgery, minimal access laparoscopic herniopathies, orchidopexies are routinely being done. Gastrointestinal pediatric surgery, thoracic pediatric surgery like decortication lung surgeries are being done routinely with good results. Another important domain of pediatric surgery work is pediatric urology. We did the first cystoscopic laser ablation in 2014. It was first laser ablation for PUV in the state of Rajasthan for vesico-ureteric reflux, which is a common pathology resulting in UTI and pyelonephritis. The traditional conventional approach is ureteric reimplantation, which is an extensive surgery. In 2016, we were the first to have initiated the cystoscopic DEXL, which is a biodegradable injection given in the ureter, and with this minimal access intervention in grade 2 to grade 4 we can achieve greater than 85% result. Here we can see the polymer being injected in the base of the ureter, and the proper dome is formed, and this cures vesico-ureteric reflux. They have recently done a robotic pelviureteric junctional obstruction pyeloplasty in the last year. Another important thing is aspect of our work is pediatric reconstructive urology. We are a high bulk center with excellent results in the field of hypospadias surgery. Even in rarer disorders like apospadias and extrophy complex, we are doing regular surgeries with good outcome. These are a few mentionable cases that we did. This is a case of congenital microgastria. The patient presented at the age of 1.5 years with the stomach of not more than 2.5 inches. We augmented the stomach successfully with a J pump from Jaipur, and it was the second successful surgery reported at that time in 2017. Another mentionable cases, transhypal gastric transposition done for pure esophageal atresia. Here, stomach was used as a conduit and was transposed in the posterior mediastinum, and the osmosis was done in the small cervical esophagus. We cater to around 1,500 OPDs, and nearly 300 surgeries are being in the department, and there is an increasing trend to it. These are a few publications, and without further delay, I would now like to request Dr. Devataman.
Siddharth, what is the problem with not having pediatrics surgery MCH? Why these students are not taking?
Sir, with pediatric surgery MCH, these seats since 2010 have significantly increased. Even in Jaipur, we have 10 seats for MCH. And until recently, that I would say like until 7-8 years back, it used to be a ground confined mainly to government institutions. Now with the better availability of pediatric intensive care, which is very, very important for outcomes in cases operated with us, the things have changed significantly. Now the number of students aspiring for pediatric surgery is also significantly increased. So we being a private institution, sometimes the students may prefer going to institutions like SMS, where the bulk is substantially more. So we have not yet done that, but I will be.
Let us try to start pediatric surgery. We can combine fetal surgery and pediatric surgery. We have robot, we have laparoscopes. Pediatric ICU is excellent at our Sharma and Jesus they are doing good job. So, think of this.
Seats are vacant in government colleges also, so students probably.
Seats are vacant in CTBS also. Seats are vacant in
Plastic and also sometimes.
Plastic also.
So if we can build up a good institute with good work being done, we can get some students to pursue that with us.
I think you should work on it.
Definitely.
Report also.
Thank you, sir. I'd like to now invite Dr. Devataman Suri, third year postgraduate resident, for the presentation.
Thank you, sir. Good morning, everyone. Our case today is a 5-month-old male infant from Kota who presented with chief complaints as narrated by his mother, which were overfeeding, recurrent vomiting, fast breathing with chest indwelling, and sunken abdomen since birth. According to the mother, the child had poor feeding since birth. The child used to latch for short duration and would take small volumes of feed. Baby was exclusively breastfed. She also felt that the child was not gaining weight adequately. Normally, a child of this age takes long naps, but according to the mother, her child woke up frequently and had a disturbed sleep. Since birth, child had around 8 to 10 episodes of vomiting a day containing milk, which was small in volume and used to occur soon after feeds. They were observed more when fed in supine position. It did not get relieved even after burping. Since birth, baby had increased respiratory rate, which was associated with chest indwelling. It was not relieved after crying or change in position. Since birth, baby had a sunken abdomen even after feeds. Normally, babies have turbulent abdomen. There was no history of bilious emesis, cyanosis, relief of distress with crying or change of posture, NICU admission or fever. Child is first male born of non-consanguineous marriage. There is no history of similar illness in the family either on the paternal or maternal side. The mother had 3 antenatal scans and all were suggestive of single live intrauterine fetus and no gross congenital anomaly. The baby was born at term through a cesarean section at another center in Kota.
See, here I want to request all the obstetricians and the radiologists, especially the ultrasound, those who are practicing ultrasound, that the scan at 24 weeks should be very, very thorough. Because unless you do thorough and have in the mind like congenital diaphragmatic hernia, herniation of the abdominal content into the chest, or transposition of the vessels, you will miss these things. Okay? You can easily miss, which can be treated during surgery, during pregnancy, or just after the delivery. Okay? So rule out all the major abnormality, and whenever these association, no gross congenital anomalies detected, there must be some congenital anomalies. And once you see any anomalies, kindly look for the heart, kindly look for the kidney very, very thoroughly. So all radiologists, all sonologists, all obstetricians should make a point to have a ultrasound 24 weeks or 20 weeks screening ultrasound. Very, very important.
The birth weight of the child was 3.4 kgs. The child has been immunized for age. Child was developmentally normal for age, exclusively breastfed on demand. Now to summarize, a 5-month-old male child presented with complaints of poor feeding, recurrent vomiting, respiratory distress and sunken abdomen. Now with the above said summary, I would like to ask the audience what all differentials can we think
अगर
of?
आप sunken abdomen बोल रहे हो तो normal abdomen कैसा होता है बच्चे से? हैं?
It's
Not necessary. बहुत ज़्यादा protrude हो जाएगा तो क्या हो जाएगा? It will be flat.
yes.
Yeah? If it is sunken or scaphoid abdomen, then there is something wrong, right? Or malnutrition. Distended, then you have to think of other things. Right? Either hepatomegaly or some intestinal irritation or obstruction.
What are the possibilities? Yes. It can be congenital diaphragmatic hernia. It could be gastroesophageal reflux disease, malrotation, or congenital heart disease. Now beginning with general physical examination, patient was examined in lying position in the mother's lap. Heart rate was 123 beats per minute. Peripheral pulses were well palpable, regular, no radial or radiofemoral delay. Blood pressure was 98 by 68 mm mercury, measured in right upper limb in supine position using auscultatory method. No significant difference in all four limbs was seen. Respiratory rate was 30 breaths per minute. Temperature was 98.5 degrees Fahrenheit in right axilla using a digital thermometer. Saturation was 95% on Lumia and capillary refill time was less than 3 seconds. There were no signs of pallor, cramping, edema, icterus, cyanosis or any lymphadenopathy. Here we can see the growth chart of the child. Green line represents 50th centile for age and child's growth is represented by the black line. At birth, child weighed 3.4 kgs which was above 50th centile, but over next 5 months there was loss of centile and child weighed only 5.7 kgs which is below 15th centile for age. Now with respiratory system examination, on inspection, no chest wall deformity or scar marks were observed. Chest movement was asymmetrical, decreased on left side. Subcostal and intercostal retractions were seen bilaterally. On palpation, chest movements were unequal, decreased chest expansion was seen on left side. Apical beat was displayed to right side. A hyperresonant note was percussed in left hemithorax. On auscultation, bowel sounds were reduced on both sides, more on left side, and
बार-बार left side आ रहा है, इससे क्या discuss निकल रहा है? What are you gaining? What are you thinking?
and there could be an anomaly over left side, most of it.
Which side hernia is more common? Diaphragmatic hernia. Right or left?
Left side.
Why?
So because during development, there is umbo-costa trigone which is left deficient.
Left में क्या होता है? Right में क्या होता है?
Sir, spleen is on.
अरे लीवर होता है ना, तो थोड़ा हाथों को नहीं जाने देगा ऊपर यार. लेफ्ट साइड में होता है, वो तो ठीक है, कोस्टो लंबर एंगल होता है, दुनिया भर के साइंटिस्ट के नाम है, दैट्स ऑल राइट. It is more on left side because left side is more hollow. Right side because of the liver, chances of getting intestine into the lung are less, right? अगर की defect है भी तो वो थोड़ा liver cover कर लेगा उसको, इसलिए hernia नहीं होगा. So that is why you are saying majority of the hernia, maybe this case is of the diaphragmatic hernia, I don't know. That might be the reason.
Bowel sounds are heard in left hemithorax. In cardiovascular system, on palpation, apical beat was felt in fourth intercostal space, medial to left midclavicular line. On auscultation, S1, S2 were heard, normally heard with no murmurs. In abdominal examination, on inspection, scaphoid abdomen was observed. On palpation, abdomen was soft, non-tender, no guarding or rigidity was present. Lower border fiber was palpable 1 centimeter below right costal margin in mid-clavicular line. It had smooth surface, regular margins and soft in consistency. Spleen was not palpable. Hernia sites and external genitalia were normal. On per vector examination, no abnormality was detected. To summarize, a 5-month-old male infant presented with history of poor feeding, recurrent vomiting, respiratory distress, and sunken abdomen. On physical examination, there were asymmetric chest movements, intercostal retractions, hyperresonant note in left hemithorax, reduced breath sounds, bow sounds were heard in left hemithorax, apical weight shifted to right, and scaphoid abdomen. Now with the above said summary, I would like to ask the audience what all differentials can we think of? These are the differentials. In diaphragm, there could be congenital diaphragmatic hernia, eventation of diaphragm, or diaphragmatic palsy. In lung parenchyma, there could be large congenital lobar emphysema. There could be also tension pneumothorax or pleural effusion, or a posterior mediastinal mass. Now, since we have a finding of scaphoid abdomen, so we can rule out tension pneumothorax, pleural effusion, posterior mediastinal mass, and large congenital lobar emphysema. Now, provisional diagnosis can be left congenital diaphragmatic hernia. To confirm our diagnosis, we planned radiological investigations comprising of a chest X-ray, PA view, followed by NCCT chest, which would be subsequently discussed by radiology department. Now to discuss the radiological investigations, I invite Dr. Sharbeen.
Thank you, Dr. Dev. Good morning, everyone. I'm Dr. Sharbeen from the Department of Radiodiagnosis. I'll be discussing the radiological findings of chest radiograph and NCCT chest of a 5-month-old baby. This is the chest radiograph, AP view in supine position of a normal pediatric patient in which diaphragmatic outline is well visualized. Both lung fields and CP angles are clear. Trachea and mediastinum is in midline. However, in our case, multicystic lucencies are seen occupying almost entire left hemithorax with mediastinum shift towards the right side. Also, that left diaphragmatic outline is not visualized and left CP angle is obscured. However, bony cage and soft tissue shadows, an NCCT chest, sagittal image in mediastinal window, coronal and axial image in lung window showing a defect in the posterior aspect of the left dome of diaphragm, measuring approximately 2.8 cm, showing the superior herniation of stomach, spleen, small and large bowel loops and left kidney in left hemithorax with underlying partial collapse of left lung and mediastinum shift towards the right side. Summing up the findings which I have discussed, our radiological diagnosis is left-sided diaphragmatic hernia, likely Bogdanic hernia because it is left-sided and posterolateral in location. So our final diagnosis is left congenital diaphragmatic hernia. Now I would like to invite Dr. Mala from Anesthesia to carry this case forward. Thank you.
Good morning everyone. I will be now discussing the anesthetic management of this 5-month-old child with a diagnosis of left congenital diaphragmatic hernia. The child was posted for the robotic assisted repair of the hernia and was referred to our department for the pre-anesthetic evaluation. The blood investigation was normal and the 2D echo was unremarkable. So the patient was cleared for the surgery after a thorough pre-anesthetic evaluation. Now we are proceed with the case. For this case, there was 4 anesthetic challenges. The primary challenge is securing the airway and providing one lung ventilation. An associate ventilation issue with one lung ventilation has the impact of capnothorax, and one lung ventilation itself will be there on oxygenation and gas exchange. It will lead to significant hypercarbia and hypoxia. Among the other challenges, there is a derangement of pediatric airway, pediatric physiology under the anesthesia, that is due to the immature organ function, loss of thermoregulation, pain and managing the fluid clearance. Concern about the cardiovascular system, as in such cases there is hemodynamic instability and the right ventricular dysfunction can be present. So for this case we must discuss why one lung ventilation is needed. The first first for robotic CDH repair, one lung ventilation is required to improve the surgical exposure. However, it comes with many challenges. As such, small infants have high airway resistance and low functional residual capacity, which increasing the risk of hypoxia. Also, in such patient, one lung compliance already compromised due to pulmonary hypoplasia and mechanical compression. So for this case, we intubated the child endobronchially with the 4 uncupped endotracheal tube, which is blindly passed into the right main stem bronchus. We auscultate the child and confirm the position of tube in situ right main stem bronchus. The ventilation strategy for this case, we started off FiO2 100% initially, then titrated downwards up to around 60 to 70%. During the surgery, we encountered a lowest SpO2 was 95% and our EtCO2 highest reading was 70 mmHg. For maintaining the lung protection, we put the patient on pressure control ventilation with low tidal volume and permissive hypercapnia was allowed to maintain the pulmonary blood flow. After the intubation and establishing the one lung ventilation for intraoperative management, the modified rapid sequence induction and with opioid-based approach were used. For the maintenance was done with inhalation sevoflurane and infusion of rocuronium and propofol. Infusion were done to maintain the accurate titration of the anesthetic drugs. The left radial artery was cannulated for the hemodynamic monitoring and the triple lumen center line secured for the IBSS. The continuous core temperature monitoring and air force warmer were used to prevent the hypothermia. For the pain management, injection fentanyl were used in intermittent doses and in the injection paracetamol as per weight. The entire surgical procedure was uneventful. The total duration under the anesthesia was 4.5 hours and the one lung ventilation time was 4 hours. Recruitment maneuvers were done to re-expand the lung after the surgical repair, and before the extubation we ensure adequate gas exchange by re-inflating the lung and performing ABG analysis. Apart from mild CO2 retention, there were other parameters on the ABG are within acceptable limits. So on the table extubation was done. Now I would like to invite Dr. Siddharth sir for the further discussion.
We shall be discussing the operative procedure. After induction of anesthesia and endotracheal intubation, once all the lines were secured, the patient was then taken for surgery. The patient was placed at the head end of the horizontally at the head end of the operating table. This is the operation theatre plan. The robot was planned to be placed at the foot end. The patient was placed in right decubitus position so that the affected side, that is the left side, is accessible to us. Once the patient was properly secured and strapped, after painting and draping, we proceeded with the surgery. Varus needle was then inserted just below the tip of the scapula, and initial insufflation was at 3 mm of mercury at a low flow of 1 liter per minute. An initial thoracoscopic evaluation was done to assess the feasibility of proceeding with the robotic assisted transthoracic surgery. Here we can see that there is a huge diaphragmatic hernia with very limited working space in the thoracic cavity. We also assess the safety of port procurement at the pre-planned site. The posterior port site is being evaluated. And then we decided that we proceed with our plan. Now, once we had decided to proceed with robotic assisted surgery, 2 additional working ports were placed in the in the posterior and the anterior axillary line, and docking was done. And this is the operative video. Here we can see the posterior axillary port being introduced. Subsequently, the anterior one was introduced, and then the insufflation pressure was raised to 5 mm of mercury, and that helped us with the reduction of the contents. And here we can see that the sac has reduced, and this is being reduced into the diaphragmatic defect, which is clearly visible to us. As the ends are muscular, we proceeded with the primary repair using 2,0-ethibond, and we can see that the suturing with the robotic device is it's very convenient to suture with the increased freedom of movement. This is another video showing the procedure being executed from the surgeon's console. The enhanced 3D vision and the increased freedom of movement with the registered instruments. The maneuvering of the suture and the suturing is made very easy. Now, once
आपने abdominal approach क्यों ले लिया?
sir, because there's in congenital diaphragmatic hernia, there's already a loss of domain in the abdomen. The small gut, large gut, all these viscera, they have never resided in the abdominal cavity. Even when we go for a laparotomy, we sometimes face the issue of abdominal compartment syndrome because it has never developed to accommodate all these things in the abdominal cavity. So if we go through the abdominal approach and insufflate, then it would be difficult to bring down the gut and reduce it. Though it has been mentioned that this approach too have been
You have done excellent job. I could appreciate that. But putting various needle in interthoracic intercostal space. Don't you think it is a dangerous situation?
Sir, actually, sir, thoracoscopic repair of diaphragmatic hernia is an established way of treating the disease. When we are doing it thoracoscopically, whether through robotics or whether through the conventional instruments, with the moment we insufflate, as in this case, for reduction of the sac, we just had to inflate the thoracic cavity. The entire content got reduced on its own. It's just that the last part had to be reduced manually. So that is a very added benefit of approaching through this time. And when we are going through the abdominal cavity, which is easier to access, no doubt that the access is much easier with the abdominal approach. But the moment we insufflate, everything will be pushed up into the thoracic cavity. That is the limiting factor when we approach through the abdominal approach.
बहुत बड़ा defect होता तो?
So it was a very huge the defect. Sir, if so that too is a known possibility, the complete aplasia of the left hanging diaphragm. In that case, we imbricate the entire diaphragmatic dome and we try to bring it to the as close as possible to the other side at the same level. But sometimes if the defect is large, we can go for prosthetic meshes as well. We can also harvest the rectus abdominis flap. That too is a possibility. But doing with abdominal approach through any of these assisted minimal access things is a bit difficult task.
So there is another reason in favor of the thoracic approaches, especially in long-standing hernias. Adhesions form between the viscera and the sac wall. So once we are doing it transthoracic, one is reducing those adhesions under vision. But if it is being done transabdominally, one is just pulling it down. So there is the higher risk of tearing the viscera and perforating them.
The ports which you use, these are the same which you use?
Sir, yes, with the Da Vinci X system that we have, the cannula, the port size is 8 mm, and that is the least, that is the limiting factor when we decide which approach and which patient we can operate. In the previous robotic systems, they had 5 mm cannula as well, but that has been discontinued. Even with this system, if we do not opt for the 3D vision, we can go for a 5 mm camera port. But again, then the instrument ports have to be 8 mm, and that would be limiting factor when deciding the age of the child who can be given this opportunity.
These are the same as for adults?
Yes, sir. It's the same. It's the same. We have instruments for neonates and for pediatric patients for laparoscopy and for thoracoscopy. But with the robotic surgery, this is a limitation at present. Sir.
एक बात बताएं, जो 5 महीने से इसको pulmonary hypoplasia हो गया है,
जी.
वो कैसे करेक्ट हो?
Sir, pulmonary जो hyperplasia can never be corrected.
जो प्रेशर लगातार 5 महीने तक रहा है और जो एल्वुलाई पिचक गए हैं, कोलैप्स हो गए हैं.
Sir, the lung can, the hyperplasia can never be treated, and that is why the limiting factor in congenital diaphragmatic hernia, whether the child is salvageable or not, depends on the pulmonary hyperplasia, which has happened around the 9th week of intrauterine life. No one can.
Hypertension लिया गया.
Sir, we routinely come across persistent pulmonary hypertension. In this case, we got a echocardiography done. We had ruled out pulmonary hypertension. We'd come to that part aspect as well, where I'd be explaining the reason why we chose this particular patient to be operated through robotics.
अपने पास नहीं होता तो लेप्रोस्कोपी से भी कर सकते हैं.
इसे थोरेकोस्कोपी से भी कर सकते हैं. वो कंपैरिजन भी मैंने आगे बताया है. So this thoracoscopy, the problem is that first of all they are rigid instruments with the ribs limiting the movement. The suturing is extremely difficult, particularly towards the lateral aspect of the defect, and then we have to do it through the chest wall by inserting a needle from outside and then tying it, and that is one of the reasons why such a high rate of recurrence is seen when the surgery is done thoracoscopically. So once the diaphragmatic defect was repaired, undocking was done after ensuring complete hemostasis. Chest drain was inserted through the camera port. All the port sides were closed, and then the patient was placed supine and handed over to and was then evaluated for extubation by the anesthesia team. The patient was then extubated on the table and was then shifted to PICU. The post-operative course would be now described by Dr. Milli Bhargava.
Thank you, sir. So I'll be discussing the post-operative management of the patient in PICU. We received the patient post-operatively in our PICU. The surgery performed was robotic transthoracic congenital diaphragmatic hernia repair. Vitals of the patient on admission were heart rate 128 beats per minute, respiratory rate 50 per minute, SpO2 95% on oxygen by face mask at 5 liters per minute, blood pressure 84 by 46 mm of Hg, which was appropriate for the baby's age, CRT less than 3 seconds, urine output 1 ml per kg per hour. 3 lines were in situ, 1 central line in the left IJV, 1 arterial line in the left radial artery, and 1 cannula on the right hand. 1 left side intercostal tube was also in situ. This is the post-op day 0 X-ray of the patient. The patient had nasal flaring, intercostal and subcostal retraction, tachypnea. Hence, the patient was taken on heated, humidified, high-flow nasal cannula, which is a non-invasive mode of ventilation. Patient was nebulized with levosalbutamol. On post-op day 1, as the patient gradually improved, we took the patient on oxygen by nasal prongs. Oral feeds were initiated in the morning on post-op day 1. After 6 hours, as the patient gradually improved, we took the patient on room air. Sequential ABGs were done in PICU, suggestive of normal pH, normal PO2 and PCO2. Lactates and glucose were slightly on the higher side, but eventually they came to normal after post-op day 1. Other management done in PICU was continuous hemodynamic monitoring was done, maintenance IV fluid was given, strict input-output monitoring was done. In antibiotics, ceftriaxone was given. Pain management round the clock was done with IV paracetamol.
What is the dose of paracetamol for analgesia, not for the fever temperature?
10 mg per kg per dose. QID.
वैसे बता दो, मैं समझ नहीं पाऊँ.
So 10 mg per kg per dose in 4 divided times.
Look, see, adult को paracetamol देते हैं कि अपन analgesics की तरह.
So we can give.
कितना dose होना चाहिए?
So adults usually will give 650 mg DDS.
And if you give less than 650, then it will not act as an analgesic. Then it will act as an antipyretic. It is important thing one should know that paracetamol in higher doses can act as an analgesic, but in the routine doses like 500 milligram, it will act as an antipyretic. Dr. Anand ji आए थे Australia. He was very fond of giving only paracetamol as an analgesic.
proper aseptic care of the surgical room, lines and intercostal tube was done. Routine care and other supportive management was given. On post-op day 1, patient was accepting feeds orally, passing urine and motion. Hence, the patient was shifted out to the pediatric surgical ward. On post-op day 2, after taking all the aseptic precautions, the ICD drain, lines and catheters were removed. On post-op day 3, as the patient remained vitally stable, patient was discharged and called for follow-up. Thank you, and I would like to invite Siddharth sir for further management of the patient.
Now, briefly discuss the embryology and our experience in the treatment of congenital diaphragmatic hernia. The incidence of this disease is 1 in 2,000 to 1 in 5,000 live birth. It is seen on more than 80%, 85% of the cases on the left side of the diaphragm. And because the right side of the diaphragm during the embryological development fuses much before than the left side, and just there is liver to protect the development of the herniation of the content on the right side. And here we can see that there is a postlateral space that was defined by Bogdalek, and with his name, this hernia bears the hernia from this side bears his name. The diaphragmatic development takes place from the 4th week to the 8th week of the intrauterine life, and there is a posterolateral area, a triangular area, where the lumbar and the coastal muscles come close, and any delay in the fusion of this part would result in a possibility of herniation. And simultaneously, the midgut is developing. It comes back into the abdominal cavity in the 9th week of the intrauterine life, and if the diaphragm has not fused by this time, it migrates into the thoracic cavity. This compression results in the hyperplasia of the developing lung and results in pulmonary hypertension. The traditional approach to the surgery of congenital diaphragmatic hernia is laparotomy, thoracotomy or thoracoscopy. The most versatile tool is laparotomy because all kinds of diaphragmatic hernias, all sizes of diaphragmatic hernias can be addressed to this. The only downside is the scar size and the possibility of adhesions. Thoracotomy is primarily reserved for right-sided diaphragmatic hernias and for recurrence in case of previously operated patient. Thoracoscopy is a good minimal access tool that we have, but there's a very steep learning curve, and there's a very high recurrence rate that has been mentioned of almost 30%. In our experience till now, from 2014, we have operated 21 cases. There's one right diaphragmatic hernia, 18 presented in the neonatal age group, and 3 presented in the infancy, 2, 5 and 7 months old at the time of presentation. All except the one that was done through robotic, and the one that was the right diaphragmatic hernia underwent laparotomy. 18 of the 21 cases survived. The average history was 17 days. This is the first CDH that we operated in our institute, and this is through a laparotomy. We can see the diaphragmatic defect with the contents in it. Once the stomach, small bowel and large bowel is reduced, we can see the last part coming as the spleen, and this is the completed repair. This is the first patient that we had operated. We can see that this scar mark has decreased over the time with experience. This is the latest patient who recently been discharged. But when we compare to those scars to this one, this is the patient who had undergone robotic surgery. We can clearly see the benefit that can be provided with this robotic approach. Now,
this patient बड़ा होता है, adult होता है, तो chances of recurrence are there.
So the chances of recurrence are there with all the 3 techniques, whether done through laparotomy, thoracotomy or through the thoracoscopy, but the chances are very less with thoracotomy. There is also one rule that when you're doing it through laparotomy, the literature says that if there is a sac, you should always resect it. But as in our case, we did not resect the sac, and it is mentioned in the literature that when you're doing it thoracoscopically, you leave the sac there. So there's this gray zone, but the recurrence is least with laparotomy, very less. There's very sparse literature regarding robotic surgery being done in congenital diaphragmatic hernia through transthoracic approach. Only case reports and small case series are available, but they state that this approach is safe and is perhaps better than thoracoscopy. We chose this patient because the child did not have an additional cardiac issue. There was no pulmonary hypertension, and the age, the child was 5 months old, the weight was 5.7 kilograms, so we chose this particular case. Then there's the certain limiting factors when we want to apply robotics to pediatric patients through the transferable approach. The cannula are 8 millimeters, and the minimum distance between the port site has to be at least 4 centimeters. And here we can see this mark on the cannula. This is known as the remote center of motion. This is 2 to 3 centimeters away from the tip of the cannula. And once the robotic instrument is inserted, another 2.4 centimeters is needed for the for the instrument to be activated. So that makes it 5.4 centimeters the minimum distance from the wall, whether abdominal or the thoracic wall, for the robotic arm to be activated. This is a recent X-ray of the child, and the child is healthy now. And this was the first robotic transthoracic CDH repair in our state. And I thank the management of MGUMST for providing us with this opportunity to learn, improve, and serve. And I thank the anesthesia department from the core of my heart. All the anesthesia department, specifically and particularly Dr. Kalpana ma'am, Dr. Tanmay, they've been very helpful, and it is because of them that we can dare to think about these things.
Anesthesia department वैसे ही बहुत अच्छे हैं.
जी सर.
Best part which I can tell that I am proud of Dr. Siddharth. Excellent. And moreover, he and his wife, Dr. Samta, Rathod in obstetrics and gynecology. She is excellent obstetrician and gynecologist, very good surgeon. Both of you should develop MCH in pediatric surgery and MCH or DM in fetal surgery or fetal medicine. And sometimes they see, very fast and very comprehensive obstetrician.